Welcome back to Decode Healthcare with Harshal. I'm your host, and today, guys, we are hitting a massive milestone with part 62 of our comprehensive 100-part ICD-10 CM guideline series. In this explainer, we are stepping right into the high-stakes matrix of section IC19E. That's right, we're tackling the table of drugs and chemicals. Our mission today is absolute mastery over 4 very distinct clinical categories: adverse effects, poisoning, underdosing, and toxic effects. We are going to conquer their mandatory sequencing reversals because, listen, in this territory, the CMS official guidelines strictly override any textbook rules for medical coding. If you get the sequencing wrong here, your claim is guaranteed to be denied. Okay, let's take a quick look at exactly what we'll be covering today. We'll start with the T-code matrix, then pit adverse effects against poisonings. After that, we'll dive into underdosing and code stacking, explore toxic effects, and finally master those strict sequencing laws. Section 1. The T-code matrix and navigating the table of drugs and chemicals. Setting the foundation to prevent denied claims starts with an explicit, non-negotiable CMS mandate. It's incredibly tempting to just find your substance in the table, grab that T-code, and throw it straight onto the claim form. But do not do it. The table is just an index. You absolutely must always verify the codes in the tabular list. Why? Because the tabular list provides the necessary instructions for those crucial 7th characters, like A for initial encounter, D for subsequent, or S for sequela. Plus, it gives you those critical code first or use additional code instructions that you just won't see in the index. Moving on to Section 2, adverse effect versus poisoning, the law of proper versus improper use. Now, this is a massive pain point for medical coders because intent literally changes everything. The crucial thing to remember here is that an adverse effect only happens when the provider and the patient did everything exactly right, but a negative reaction still occurred anyway. Think about it. The medication was correctly prescribed, the dosage was spot on, and it was administered properly, but the patient still developed tachycardia, a gastrointestinal hemorrhage, or maybe renal failure as a result. That's an adverse effect. By contrast, poisoning occurs the very second a drug is used improperly. And honestly, it doesn't even matter if it was a prescription error made by the provider, an intentional overdose by the patient, taking someone else's medication, or, if the patient just decided to wash down their perfectly good antibiotics with a margarita. The moment the usage becomes improper, CMS guidelines dictate that it immediately crosses the line from an adverse effect into a poisoning. And because of this fundamental difference in intent, we get a mandatory sequencing reversal. This is huge. For adverse effects, you must sequence the manifestation, like the symptom or condition first, followed by the T-code for the drug, which will actually always have a 5th or 6th character of 5. You never, ever list the T-code as principal for an adverse effect. But for poisoning, well, the rule flips entirely. You sequence the poisoning T-code first to identify the intent, followed by the secondary codes for all the resulting manifestations or injuries. Let's actually see this in action. If a patient takes their amoxicillin exactly as prescribed, but they break out in a rash, we code the manifestation, so L27.0 for the drug rash, in slot 1. Then, T36.0x5A goes into slot 2 to show the adverse effect of the penicillin. However, if that patient accidentally overdoses, well, that's improper use. So the poisoning code, T36.0x1A, takes the lead on the claim in slot 1, and the resulting coma, R40.20, gets pushed to slot 2. All right, Section 3. Underdosing and code stacking. Why less isn't more. This brings us to a complication that frequently trips coders up and causes major claim denials, which is underdosing. Now, underdosing simply means the patient isn't taking enough of their medication, even if they decided to discontinue it completely on their own initiative. And here's a really important note straight from the CMS guidelines. Documentation of a change in the patient's condition isn't even required to assign an underdosing code. Literally, just the documentation that they are taking less than prescribed is enough for you to code it. But here is the absolute golden rule you have to burn into your memory today. An underdosing code can never, ever be listed as the principal diagnosis on your claim. Think of it this way. If a patient has a relapse or an exacerbation of their medical condition because they stopped taking their meds, the medical condition itself is always what brought them through the hospital doors, right? So it must be sequenced first. So to accurately report this, we use a technique called code stacking. First, you list the medical condition. Then, you add the underdosing T-code, which is identified by a 5th or 6th character of 6. And finally, you stack on a non-compliant Z-code to explain exactly why the underdosing happened. This 3-part stack gives payers the precise sequence of events. For example, Let's say a patient suffers intractable seizures simply because they couldn't afford their medication. You'll carefully stack the codes exactly in this order. Slot 1 gets G40.901 for the seizures. Slot 2 gets T42.4x6A for the underdosing of benzodiazepines. And Slot 3 gets Z91.120, which is the specific Z code documenting that the intentional underdosing was due to financial hardship. Doing it this way paints a pristine, undeniable clinical picture. Okay, so we've covered therapeutic and improper drug use. But ask yourself this: how do the guidelines shift when a patient is exposed to something that was literally never meant to be ingested? What happens when we leave the pharmacy entirely and enter the realm of environmental hazards? That leads us into Section 4, Toxic Effects Explained, Non-Medicinal Hazards. So this is the fourth and final clinical category in our matrix. Toxic effects are reserved entirely for non-medicinal substances. We're talking everything from carbon monoxide to rat poison, snake venom, and even heavy metals like lead. When a harmful substance like this comes into contact with a person, the guidelines classify it distinctly from a poisoning, even though the coding logic itself is actually quite similar. And what's really fascinating here is that toxic effects follow the exact same sequencing rules as poisoning. That means the toxic T code leads, followed immediately by the organ damage or the symptoms. Let's see how this builds out in a real claim. If a patient suffers an anoxic brain damage from accidentally inhaling carbon monoxide, you lock T58.01XA, the toxic effect of carbon monoxide, right into slot 1. Then you place G93.1 for the anoxic brain damage into slot 2. It's simple. The hazard always precedes the harm. Finally, Section 5, Mastering the Sequencing Laws to Secure Those Clean Claims. To navigate this high-stakes matrix with total confidence, the final piece of the puzzle is correctly identifying the intent characters for both poisonings and toxic effects. CMS uses these very specific 5th or 6th characters. Character 1 means accidental or unintentional. Character 2 is intentional self-harm. Character 3 is assault. Character 4 is undetermined. And remember, the CMS official guidelines state that if the intent of a poisoning is completely unknown or just unspecified in the documentation, you must default to accidental, so Character 1. You only use undetermined if the medical record explicitly states that the intent absolutely cannot be determined. By mastering Section IC19E, you are protecting your providers from massive denials. Thank you so much for joining me for Part 62 of Decode Healthcare with Harshal. Please make sure to subscribe, hit that like button, and share this explainer with your fellow coders who really need to master the T-code matrix. And get ready, because in Part 63, we are tackling Section IC19F, Complications of Surgical and Medical Care, where we'll dive deep into mechanical breakdowns and infection sequencing. But I'll leave you with this final thought. The next time a patient comes in with a complex complication, will your coding tell the true medical story, or will a simple sequencing slip cost your practice thousands in denied claims? Think about it. I'll see you in the next explainer.